First, I'd like to thank Dr. Gertz for the history of myeloma. I was a medical history minor at Michigan State, and actually how I got into myeloma was that I had talked to Dr. Bob Kyle, who has lived the history of myeloma, and he taught me about the history of the disease. He's also a history buff and really got me into the history of myeloma specifically. And it's incredible to see the progression of myeloma over the years. I think one important point that Dr. Gertz had mentioned was that the patients, that when Dr. Barloghi started using thalidomide, it was because a patient's wife had asked them to, and which really speaks to patient empowerment, that a patient talked to a doctor, demanded something for her husband, and got us to where we are today. We were stuck in a chemotherapy area before a patient's caregiver said we need to change things. And so the reason we're here today is because of patient empowerment. And again, this is the tip of the iceberg of where patient empowerment can go. Speaking of, I'm going to talk about myeloma therapy. And specifically, I'm going to talk about the differences between patients with multiple myeloma. The reason that's important is that, if you can imagine that if you only have one type of apple, so if you have Granny Smith apples, not my favorite apple, and the only thing you had was Granny Smith apples, and that's all that the grocery store had, you wouldn't know much about fruit if you only had one apple to work with. The reason that I know I like, personally, Fiji apples is because there's a variety that I tested along the way and found that that's my favorite type. And I found out the types that I don't want, I found the types I do want, and I'm more empowered because of the diversity of different apples. And the only way that we can get to a cure for multiple myeloma is understanding the diversity and the differences in this disease between the races and ethnicities. There are my disclosures. So we're going to talk about the race and incidence of myeloma, precursor disease, the precursor disease MGUS, monoclonal gammopathy significance, that Dr. Kyle had discovered. We'll talk about the differences in presentation and biology between races and ethnicities. Treatment outcomes, disparities in clinical trials, and the things that we're doing to solve those disparities in clinical trials and in treatments. So to talk a bit about race and ethnicity. So the per 100,000, so if you get 100,000 people and put them in an arena, about 8.7 men will have, overall 8.7 men will have myeloma, 5.9 women will have myeloma. But if you look between the different ethnicities, they're pretty much even Steven, except for blacks that have a much, much higher, in fact, double the incidence of myeloma between men and women as compared to all other races. And also I would lend your eye to to Asian patients who have a much less. And so there's something in there. There's something important in there about the differences in the incidence of this disease. In fact, black patients have twice the incidence. And in fact, this isn't an American issue. This is something worldwide. Back in 1968, it was found that Jamaicans had a higher incidence, or Caribbean people had a higher incidence of myeloma than the United States. And that was one of the first times that we saw the racial difference. And if you look in the United States, about 21% of myeloma patients will be black here in the US. When you, again, looking at per 100,000, again, the incidence has been rising for all races, and blacks and orange are much higher, as I had mentioned. And you look at the mortality, because of the higher incidence, the mortality also mirrors that. And again, looking at that, thank goodness for all groups, it's going down. So the question is, and the biggest question I get asked is, well, why do we have these differences in incidence and prevalence of myeloma? There was a study that was done by the National Health and Nutrition Examination Survey, which basically just looked at everyone over age 50 to see what the prevalence of myeloma precursor disease, specifically the MGUS, was, and found that in green, the blacks were higher than whites for the precursor disease. Not everyone that has MGUS will end up with myeloma, but all patients that have myeloma at one point has had MGUS. So that gives us a bit of insight into the higher incidence of myeloma. And it occurs younger, so MGUS occurs at a younger age in blacks and in whites. But then it was, well, what's causing this higher incidence of in blacks? And they looked at everything. They looked at tobacco use, education, socioeconomic status. Could not find a reason why that double incidence occurs. Some people have said that maybe it's a higher BMI, but that's actually across the board between all races. And then again, if you go to Southern Africa, this was an abstract that was at our last meeting at ASH. Again, you see this higher in a concentrated group that's really all black African. Again, you see a much higher incidence of, in fact, light chain, but a higher incidence of MGUS in that black group. So again, which rules out things like industrialization that we see here and environmental causes as the primary cause of that higher incidence. So, and again, it's not because we haven't looked, but we're still searching for the reason for that double incidence. It's probably something that's deepened within our genome that is causing that higher incidence in blacks, and why in people of Asian descent it is so low. So let's talk about some of the differences besides the incidence. We know that black myeloma patients will present 4 years younger than their white counterparts, that black patients will present with more anemia at the time of diagnosis, higher calcium levels, more renal insufficiency, those CRAB myeloma-defining events, and more extramedullary disease. Actually, though, blacks will have less in the way of bone fractures because blacks have a higher bone density than whites. There's some studies that suggest that certain translocations are more common in black patients, the 11, 14, 14, 16, 14, 20. I'll show you that's still a bit controversial, but what's important is that 11, 14 is a target for the venetoclax drug in multiple myeloma, a very powerful agent to inhibit BCL2, which the 11, 14 types of myeloma overexpress. Importantly, black patients are less likely to have the high-risk cytogenetic features such as deletions of 17p and additions of chromosome 1, which are, again, more difficult to treat myeloma. And several studies have shown that. So the question is that what if you crack open those myeloma cells? What if you look at the DNA inside these myeloma cells? Can you figure out some of these differences? And the answer is yes, that when you look at the DNA and you look at different mutations between blacks, whites, and Hispanics, you actually see that they're different. So even though these myeloma cells, if I get a myeloma cell from someone that's white, someone that's black, and someone Latino, all those cells look alike. When you crack them open, actually there are kind of subtle differences between it. That black patients will not have a BRAF mutation, a target that's been used to treat other types of cancers. And again, white patients are more likely to have the high-risk mutation of TP53, which is on that chromosome 17p. That Hispanic patients have their most common mutation that Hispanics will have that whites won't have is IR4 mutations. And blacks will have different mutations that are associated with decreased progression-free survival with the PS140. So again, there are differences when you crack open those myeloma cells dependent upon race and ethnicity. There was a study that Jeff and I have been talking quite a bit about over the past few years, where a group had looked at 350 cases of myeloma precursor disease, so the MGUS and smoldering patients, as well as newly diagnosed myeloma, and did whole genome sequencing. So they looked through all the genes in these myeloma cells. And also, instead of asking people what race they belong to, they actually did genetic testing to see which race they belonged to. 53% of patients were European dominant, 26 were African dominant. The American and highly admixed were people of mixed race and Latino patients. And then there were Asian patients, again, identified by their genetics. And what they found was something really interesting, that the mutation burden was higher in whites and lowest in people of the African clusters. And so again, speaking to differences between the races and ethnicities when you crack open those myeloma cells. That African American patients had lower clock-like signatures. And so these are mutations that occur and occur and occur on a clock-like pattern, that the clock ticking for more mutations was lower in African Americans than it was in people of European. And the enzymes which actually create some of these mutations, APOBAC mutations, or APOBAC activity causing more mutations, was higher in people of European than African descent. And then the little black dots are the number of mutations that patients will have. And you see that in the light blue column where the European dominant patients are, there's way more mutations that are found in the myeloma cells of white patients, European dominant patients than black African American, really more than any other group. Which again speaks to the differences that we need to exploit in trying to cure this disease. The authors said that African American myeloma is biologically different by genomic and mutational signatures, and that whites were different. Again, very important to know when we run these clinical trials, we have to be very aware that there are differences and that we can't, again, look at Granny Smith apples and expect to understand the complete nature of fruit, if that analogy is still working for you. And then I thought this was super interesting. This was at the International Myeloma Society meeting. They had actually looked at the microenvironment. So the question is that we know the seeds are different between patients. The myeloma cells are different between the different races and ethnicities. What about the soil? What about the bone marrow microenvironment? Are those different between the different ethnicities? And what they did is that they did single-cell RNA sequencing of cells inside the bone marrow, specifically looking at the cells around the tumor, not looking at the tumor itself. And they found that black patients had significantly higher cytotoxicity signatures, which meant that some of those T cells, which help fight off cancer cells, were actually more abundant and more active in black patients than in white patients, and that the immune microenvironment was different between the two. And again, Dr. Gertz had talked about how we're using these new immune therapies to treat myeloma, and some of these alterations may actually favor black patients and white patients. Again, very important to know when we're running clinical trials and doing research that there are differences not only in the myeloma cells themselves, but actually the bone marrow microenvironment of patients. So if all this is true, and you would say, Craig, that's a lot of technical lobbledy-boo, my daughter's term, do you actually see that? And I can say yes, that there are several studies that have been done looking at myeloma care. So there are lots of disparities in this country, and I'll show you in a little bit, about myeloma care based on socioeconomic, race, and ethnicity. But if all things are equal, so the VA medical system, everything's equal. If anyone has worked or has gotten their care through the VA, it is very scripted and very set. There really isn't an ability to deviate from the script that they have at the VA Medical Center. They looked at the difference between blacks and whites in outcome, and everyone got, everyone who's eligible got stem cell transplant. Everyone got the same therapy. And actually, when you look at the green versus the blue, that the green bar, which are black patients, actually did better than the white patients, except for they were pretty even-steven in people over the age of 65. Meaning that, again, that there may be a slight, and this is just one study that looked at this, there may be, again, slight differences or significant differences in some cases between survival and outcomes based on race. But there are differences, and there are significant differences, especially with toxicity of some of these drugs. That, again, you know, the Revlimid, pomalidomide, Revlimid, you know, I was working on back in 2001, and these drugs were being used, again, in the early 2000s. It took 21 years for us to realize that there were significant toxicity differences between blacks and whites, and specifically that in 2001 they had published that black patients were getting darkening of the skin compared to white patients. And again, it took that long for this, and I'll show you why it took so long to find this toxicity. I had patients over the course of my career that complained of this, and I didn't have any textbook or any papers to justify it. I saw it, but I was like, oh, maybe this is a one-off, maybe this is something else. I remember seeing patients at dermatologists because I wasn't quite sure where this was coming from, because it took so long for us to find this difference. And I'll again hit upon that in a bit. Some other differences is that the determination trial, one of the largest trials that compared everyone in this study had newly diagnosed myeloma. They were randomized between the 3-drug regimen, Velcade, Revlimid, dexamethasone, with intention to transplant or no transplant. So this is transplant versus no transplant, followed by consolidation and maintenance therapy. And overall, the big news of this study was that overall, that transplant patients had a longer progression-free survival, but no difference in overall survival. However, for black patients, the patients that didn't get transplanted, actually the time for relapse wasn't actually reached compared to the patients that did get transplanted. So again, differences. And when you look at the graph at the bottom, the black patients are in green, the white patients are in purple. And you see that for white patients, basically all the subgroups that getting a transplant with induction VRD therapy was better. But for black patients, it wasn't necessarily true all the time. Does that mean that black patients shouldn't get transplanted? Absolutely not. That everyone should get the same therapy as I showed you with the VA study. But does that tell us that we need a better understanding about these differences? That means that we need a better understanding about these differences, again, in order to cure everyone. Some more differences regarding CAR T cells. So Dr. Pianko will talk about CAR Ts and immunotherapy in a bit. But you know, CAR T cells, when we re-engineer those T cells in order to treat, to have the T cells attack myeloma cells, the newest therapy that we have on the block. And one group throughout the South and Southeast and Southwest looked at outcomes of myeloma patients, 17% of which were black, 11% were Hispanic. They found that black patients were more likely to have the cytokine release side effect. So when these T cells go into the body, when they fight myeloma cells, they can cause low blood pressure, fevers, difficulty breathing, and even though a lot of those are low grade, they can cause some side effects. Those side effects are more likely to occur in black patients with longer hospital stays because of those side effects. But thank goodness there was no difference in the severe grade 3 cytokine release or eye cancer or neurologic toxicity. So again, probably the theory is that black people have a higher inflammation level, and then when you have the inflammation associated with CRS on top of that, that it makes it a bit higher. I think one really point that we need to really figure out is why there was a lower response rate for Hispanic and Latino patients compared to their black and white cohorts. Thank goodness there was no difference in racial, ethnic, no difference in overall or progression-free survival based on ethnicity or race. And at IMS, they said they're going to update this database so we can learn more about how these patients do on a long-term basis. And to talk about bispecifics. So again, Matt will talk about bispecifics in a bit, but that's when there's an antibody created which gets those T cells to attack the myeloma cells. This has been one of the big revolutions in myeloma therapy. Teclistamab was approved, which attaches to that protein on myeloma cells, BCMA, and attaches to the CD3 on T cells, brings them together so the T cells will attack the myeloma cells. Teclistamab was the first approved in October of 2022. Talquetamab goes against another protein on myeloma cells, GPRC5. GPRC5 is on myeloma cells, CD3 is on T cells. Same effect, the T cells kill the myeloma cells. That was approved in August of last year. LRAN was approved right after that, another BCMA CD3. And then Linvo was in clinical trials. It's another a bispecific antibody. It actually was pending FDA approval, went up for FDA approval, and then was declined due to manufacturing issues. But it's still, and again, you can see the response rates in patients that are heavily relapsed and refractory are remarkably high. But one thing to look at is the number of blacks and different ethnicities that were on those trials and how many were actually reported. And you see that in the LRAN, TEC, and Linvo trials, again, numbers are about in the 200s, but the number of Black and African American patients on those trials is, in the double digits, around 20, 10, and 3 in some standpoints. This is probably the most important statement that I'll say in my entire talk. Again, going back to the apple analogy, that diversity and accurate representation of minority groups is needed in clinical trials to appropriately interpret the role of these therapies and guide management and patient needs. So you need to know how these are. I showed you that there are differences in biology, there are differences in the cells, there are differences inside the bone marrow, that there are differences across the board. In order to be able to apply these therapies to individual patients, you need to have appropriate representation on age, gender, race, and ethnicity to know that these therapies work for everybody. So if we look at LRAN in Black patients, you'll see that a lot of the things I have mentioned are validated in looking at Black patients getting LRAN. That the patients were a little bit younger, that the patients had Black patients had more extramedullary disease, that patients had a bit more higher stage disease. They had a little bit difference in performance status. But when you look at outcome, that Black patients compared to white patients, maybe, even though the numbers of Black patients are really small, that maybe there was a little bit that it's at least even, Stephen. Maybe if you blur your eyes, you can say it's a little bit better. And all the outcomes that you look at, progression-free survival, overall survival, and duration of response, were not reached yet. So those patients, again, statistically enough are responding where they can't say how long the therapy lasts. When you look at side effects for that cytokine release syndrome, the neurotoxicity infections, again, pretty even, Stephen, thank goodness, because when I looked at this data, I was a bit worried that maybe we would see some of the higher cytokine release syndrome that you see in CAR-T be reflected in the bispecifics, and that's not necessarily true. That everything for toxicity always is pretty even, Stephen, between the races. When you look at teclistamab and Linvo, again, it's just hard to see the overall, but you can see again that Black patients had at least equal, if not maybe slightly better response rates than overall response rates than white patients. Unfortunately, the number of Hispanic patients wasn't reported. At one point, I even called the investigator, or I emailed him because he was overseas, so I didn't call him, and asked him about Blacks and Hispanics on this trial, and they didn't record that very well. And so one thing that we are really encouraging investigators to do is to make sure that we keep track of this, because again, of the significant differences that we see. When you look at Linvo, again, you can say that the response, even though numbers are small, responses were equal, if not maybe a little bit better for Black patients compared to other ethnicities. So I think I made an argument that we should really be looking at differences in, we need to have diverse populations in clinical trials. And when you look at what's happened so far, again, I mentioned that about 21% of patients in the United States that have myeloma are Black. However, when you look at the clinical trials where the drugs have been approved for myeloma, the Blacks only represent 5% of the people on those trials. So how do I know, again, that these drugs work equally for everyone if the representation for, and I would say for Hispanics, for Latinos, same thing, way more patients than there are people represented in clinical trials. I don't have one for age, and I'll show you in a second. Age is the same thing. That, you know, how well do these drugs work in the elderly people over age 85? I would say that we don't have enough data to say that comfortably. When you look at trials, the FDA did this. So I should mention the FDA looked at independently the number of people, the diverse populations that were put on clinical trials, specifically Black patients, that were put in clinical trials that were submitted for FDA approval. And you can see that out of 23 trials that were submitted, some of them didn't say anything about race, but the median, the average number of Black patients enrolled in those trials was about 5%, which is how I got that graph earlier. Better in the United States than outside the United States. And again, under the actual national percent of Black patients with myeloma. And you look at the lenalidomide trials, look at how low that number is for the lenalidomide trials. That's why it took us 20 years to see the side effect, because the number of Black patients enrolled in this trial that were approved by the FDA were so low that we missed out on a very important side effect of this drug. And you would say, Craig, are things better today? And the FDA just looked at this most recently and published this a couple years ago, that again, for people who are extreme elderly over age 85, again, single-digit numbers. We don't know how well these drugs perform in the extreme elderly because of so few patients were enrolled in those trials. When you look at Blacks, Latinos, other ethnicities, single digits of enrollment around the world and in total, thank goodness in the United States, we are much better at recording and doing that. And you would say, well, in Europe, there aren't any Black people. There was a study that was done at IMS this year in Great Britain that shows that actually at hospitals in Great Britain, the representation of people of Caribbean or of African descent are almost as high as it here in the United States. They had like 17% in some hospitals in Great Britain that had Black patients and people of Caribbean descent. So again, we need, even our European colleagues need to get on the ball, and again, for Latinos, single digits. For CAR T, and this is not just for myeloma, for all CAR T, again, very low representation of these drugs approved by the FDA because there weren't enough people of minority descent that were put on the trial. And this is one of the slides I think is important, is to look at death. You're looking at death with myeloma, mortality. Their excess mortality for Blacks is in red. No particular minority excess death is in gray. And Hispanics, I think, is in green. You look at where clinical trials and the CAR Ts are done, or the blue dots in their capture area, there are huge swaths of this country where there are no clinical trials, there's no access to CAR T, limited access to bispecifics, and people are dying of this disease in excess. Thank goodness in Michigan, you can see there are pockets, counties that do have excess mortality. But even when you look at Michigan, these swaths and the capture rate for clinical trials is fairly limited. Again, there are huge areas that need these clinical trials available to them. And what difference does it make if we don't enroll diverse populations? Well, not only will we not get to a cure, but the recommendations that we leave to treat this disease are one-sided. They predominantly are based on studies done on white patients, and that the IMWG guidelines, which a lot of people follow, actually, 2.6% were black in those recommendations. So how can you know that the guidelines that are developed are representative and work for everyone when there is such low representation? And we actually, Dr. Zonder and I have an abstract that's going to be at ASH this year showing for the NCCN guidelines it's not much better. It's not much better. That still, the guidelines reflect a very majority population, but don't encompass recommendations for everyone. So what are you going to do? So what are we doing? What are we doing to fix that? Well, what we're doing, I love The Sopranos. It's like I miss my hair and I miss The Sopranos. That the FDA said enough's enough. We're done. We're done. The doctors aren't doing it. So we're going to tell the doctors and we're going to tell the companies that they need to do this. They need to enroll diverse populations in clinical trials. And so they came up with an action plan to improve participation. And so they have a roadmap that is clear as, for a government document, clear as day in how to enroll diverse populations in clinical trials. And the good thing is that people complained, including me, that, well, the FDA can't enforce it. And they just said in August that in 2026, it is enforceable. That if you try to do a clinical trial and you try to enroll 99% white men on a clinical trial, the FDA will tell you go back and enroll diverse populations in your trial. And I applauded, I was the only one, but I applauded the FDA for doing that. They also have recommendations of doing telemedicine and being able to distribute clinical trials to those areas that I showed you had excess death. And so they just put out guidelines of how to do clinical trials in remote areas using telehealth and other modalities. The FDA also looked at, well, why are we enrolling such low numbers of people of ethnicity, and looked at screen failure rates. So these are patients that want to go on a clinical trial, but couldn't go on a clinical trial because of the way that we wrote it. And 24% of black patients were made ineligible for clinical trials because of how we wrote them. 20% of Hispanics, which are higher than whites. And some of those are because of lab results. Well, we know that 66% of blacks in the United States have something called a Duffy null phenotype, what used to be called the neutropenia of ethnicity. That's the old term of it. And that means that black people just have slightly lower neutrophil counts than their white counterparts, but there's no adverse risk associated with those lower white blood cell counts. But we wrote the clinical trials and cut and paste them over decades, which excluded patients from that. And in the determination trial that I had mentioned, that we found out, and in that trial, 64% of the black patients had the Duffy null. So now what are we doing to be inclusionary in that? Is that we're rewriting our clinical trials to be inclusionary, to test for Duffy null, and saying that if your neutrophil count is lower because of where your parents came from, that we will include you on the clinical trials instead of excluding you like we've done for decades. So again, that's what we're doing. Another thing that we're doing is educating our colleagues and saying that people want to go on clinical trials. It drives me bananas when I hear, well, black people and old people and Latino patients don't want to go on clinical trials. That's not true. That when that has been looked at, that actually Latinos, black patients are more likely to want to go on a clinical trial than their white counterparts. And just at the last ASH meeting in the South, they actually interviewed black patients and found that they're willing to participate in clinical trials. So the excuse that, well, nobody wants to go on it is not true. And I say that every time I talk to my colleagues. And then we wrote a paper earlier this year on how to actually do this. And again, with the goal of having diverse populations in clinical trials, we said that we need to expand the eligibility criteria. We're doing that to include diverse populations, minimize minimize the burden on clinical trials on patients. So we are doing that. We're working with different agencies to help get patients to the clinical trials, to give financial support to patients, because being on a clinical trial can be a bit expensive. And I think one of the most important things is doing what we're doing right now, to talk to people about clinical trials and about myeloma. So I spent a lot of the summer in the South, right in that area that has a higher mortality, talking about patient empowerment, talking about clinical trials, and getting people to show that clinical trials are not only safer than they've ever been, but more effective than they've ever been. So we need to keep spreading the word. So in conclusion, patients of African descent have twice the incidence. The biology, I think, hopefully I've showed you, is a bit different with equal therapy, that the outcomes are pretty much the same, or equal, if not a bit better. But there has been a less increase in population-wide survival in myeloma between the races. And there was just an abstract that was at IMS that says that that's even true today. That hasn't gotten better over the past several years. We need appropriate representation in clinical trials. And again, this is the way we are working very hard to make things equal so that we have all myeloma therapies for all patients. And there's my two homes at Carmanos in Detroit and Carmanos in Lansing. Thank you.